This program is brought to you by Emory University.
Okay, good morning. It's my pleasure to introduce Dr. Ben Levine. But Dr. Levine is the founder and director of the Institute for Exercise and Environmental Medicine at Texas Health Presbyterian Hospital, Dallas, where he holds the S. Finley Ewing Chair for Wellness and the Harry S. Moss Hart Chair for Cardiovascular Research. He is professor of internal medicine and cardiology and distinguished professor of exercise scientists at UT Southwestern Medical Center. Dr. Levine earned his BA in human biology at Brown University, his MD from Harvard Medical School. He did his residency and internship at Stanford, and then did cardiology fellowship at UT Southwestern, where he trained under the renowned cardiovascular physiologist Gunnar Blomquist and Jerry Mitchell, who is a hero to many of us. Jerry Mitchell was. Dr. Levine founded the IEEM in 1992. It is now the most prominent human physiology research laboratory in the United States and probably the world. His research interests include the cardiovascular response to exercise training, deconditioning, aging, physiology during spaceflight, and high altitude. He works extensively as well on HFpEF, POTS, and assist device non-pulsatile physiology. Dr. Levine is also part of the Emory family in that his daughter graduated from Emory College in 2015, right? And so it's a real honor to have you here today, and thank you for coming, Ben. And so please join me in welcoming Dr. Levine to the Division of Cardiology in Emory. Thanks so much.
Thanks, Dave. Well, good morning, everybody. Thanks for making it in on such a rainy day. It's a pleasure to be here. What was playing behind you was called a star trail. It was put together by Don Pettit, one of our subjects in some studies I'll show you on the space station. It's basically pictures of the stars and lights on the Earth on the International Space Station, so it's pretty cool. I'm going to talk to you about the human cardiovascular response to spaceflight and try to pull together some of these apparently disparate areas of interest that I have that David mentioned to you. And what I want you to keep in mind as we go through this talk is, what is this relationship among fitness, bed rest, aging, and spaceflight? So I'd like to start where for me is sort of the beginning, perhaps the most famous study in the history of our field. It's the Dallas Bed Rest and Training Study. They took 5 young men, put them to bed for 3 weeks, and trained them for 2 months, and virtually everything we know about the adaptive capacity of the circulation starts with that study. Here's a young Jerry Mitchell and Gunnar Blomquist and Bengt Saltine. For those of you who fight with editors and reviewers about shortening your manuscripts, this study took up 78 pages in circulation back in the 1960s. Now, here's just one adapted figure from the slide, which is important, which shows the maximal oxygen uptake in these 5 young men, some who were relatively fit, others who were less fit, after 3 weeks of bed rest. Now, I was only 12 years old, so I didn't have anything to do with that study. But in the mid-90s, 1996, we found those same 5 guys and brought them back to Dallas now 30 years later. And what was amazing is that not a single one, not one person, was in worse shape after 30 years of aging than they were after 3 weeks of bed rest when they were in their 20s. So 3 weeks of bed rest was worse for the body's ability to do physical work than 30 years of aging. It's a pretty profound observation, and one that has set me on this course in trying to understand what links all these different factors together. So Gunnar Blomquist, who was my mentor, who died now almost 10 years ago, really was the founder of this whole field. He took the bed rest component of the study and morphed it into the spaceflight. And if you're ever interested in doing some more reading in this field, this monograph, which Gunnar published in the Handbook of Physiology in 1983, is still the best thing that's ever been written about gravitational physiology and the cardiovascular system. So I urge you to look at it. But what drove most of the early research in the cardiovascular system in space was this observation, the fact that the vast majority of astronauts, up to 2/3 of them, can't stand for 10 minutes when they come back from being in space. So between a quarter and 2/3 faint within a 10-minute stand test. And that was quite disturbing, and it really was the focus of much of that early research. And so to address that, I want to just make sure we're all on the same page. I know that we have some fellows in the room somewhere, either here or electronically somewhere else. So I want to just talk briefly about the pathophysiology of orthostatic intolerance, which ultimately centers in the brain. The brain has a modest ability to adjust its blood flow for variations in perfusion pressure, but quite frankly, it's relatively small. And at the end of the day, cerebral perfusion depends on mean arterial pressure. Remember that blood pressure depends on three things, and three things only: the heart rate, then the stroke volume, which make up the cardiac output, and total peripheral resistance. So if this is going to fall, it has to be because of one of these things. Either the heart rate is too slow, too fast if it's an arrhythmia, the heart is underfilled or can't contract, or you have vasodilation, and that's it. That's what causes hypotension and cerebral hypoperfusion. So what does that have to do with gravity? Well, when I stand here in front of you, it's the stroke volume, the volume portion, that's influenced by gravity. So almost 3/4 of my blood volume is below my heart. Gravity is sucking blood into my feet in the upright position. And if I cross my legs like this, here in this picture, and squeeze and push the blood back to the head, people, even with autonomic failure, won't faint. You can use an impedance threshold device, which is used often in CPR now, to suck blood, use the respiratory muscles back. And it turns out that if you do, for example, an unsupported tilt study, and you have people just stand quietly, over about an hour, virtually everybody will faint. But if you have them cross their legs, nobody faints. So it's quite effective. It's basically lying down while you're standing up. And it emphasizes that gravitational component. Of course, there are other factors which can exaggerate or exacerbate this physiology. So if you send blood to the skin, right, when you're hot, that reduces central blood volume and exacerbates orthostatic intolerance. If you cool the skin, it makes it better. So what happens if I take this guy and I send him into space? Well, immediately, all this blood that's below the heart, now you relieve that gravitational gradient, it all comes back to the chest. And the head gets full, the upper body gets full, and the astronauts call that the puffy face bird leg syndrome, because their faces get a little full, gravity's not sucking their skin down, and they really feel this throughout the whole time that they're in space. While you're in space, the body adapts to that. As you cause central hypervolemia, you excrete urine, you lose about 1/2 liter of plasma volume, and that's just fine while you're in space. It's pretty similar to when you're on the ground. The problem comes when you come back down to Earth. Now, gravity once again is sucking blood below your heart. You're hypovolemic, and that exaggerates and exacerbates the orthostatic hypotension. Well, this is the theory, at least. What's the reality? And in the early 90s, we did the first invasive studies in the space program and did right heart catheterizations, at least CVP. And Drew, do any of you know Drew Gaffney, who's used to be clinical chief at Vanderbilt? He was one of the faculty members at UT Southwestern. I put his catheters in, the first human to fly with a central venous pressure catheter in space. And a lot of the technology that you will use in PICC line was developed for this purpose with Baxter. And here's the data. Here's Drew's CVP while he was sitting in the suit room. It's about 5. When he lay down in the orbiter on his back with his feet up in the air, it goes up to 10 or 11, and then he sits there and sits there and sits there and sits there for 2.5 hours urinating into his diaper, so CVP gets progressively lower, and then the shuttle takes off. And you can see a lot of the noise in the front to back, GX pressure load as you press on the chest. And then what happened when he got into space? CVP went to 0. Didn't go up, it went down. And we were panicked. We thought we must have screwed something up, right? But it stayed that way for hours. There's no question. And in fact, we did it in more than one astronaut. We did it in 3 of them, and they all showed exactly the same thing. virtually zero or close to zero in 0G. Now, what happened to the heart size? Well, it turns out that if you use echocardiography and you look at pre-flight versus that first day in flight, there was about a 20% increase in heart size. So decrease in pressure, increase in heart size. How the heck can that happen? Right, notice that over time in space, this is days now as opposed to hours, over about 10 days, you drop down about 20% below baseline. That's sort of what we thought would happen theoretically. So does anyone have any ideas, how do you get a lower pressure and a bigger heart? Well, the answer is it's transmural pressure that's important. And so people forget how much external constraint, the weight of the lungs and the chest and constraint of the pericardium play on setting cardiac chamber compliance. And when you go into space, all that is taken away. So you fundamentally change the cardiac pressure volume curves. Obviously, transmural pressure is going up. And if you measure esophageal pressure and take people on a parabolic flight, in fact, esophageal pressure goes down lower than CVP. So that's the only way that this can happen. You change the fundamental pressure volume constraints by removing the weight of the chest. So we talked at the beginning that the issues with orthostatic tolerance are stroke volume, which is the gravity component, and then the autonomic reflex response of heart rate and vascular resistance, which is the response to the upright posture. And so in the early days of the program, there was a lot of concern that maybe sympathetic activity was suppressed, and maybe we couldn't vasoconstrict as much. And so the next thing we did was another set of kind of bold, invasive experiments. This is the laboratory on NeuroLab, a lower body negative pressure device. Dr. Jim Pawelczyk doing sympathetic nerve recordings while we're measuring transcranial Doppler and beat-by-beat blood pressure. We're actually recording muscle sympathetic nerve activity in space. And what happened? Well, here's beat-by-beat blood pressure and sympathetic nerve activity. In case you haven't seen these before, each one of these spikes is an integrated burst of sympathetic efferent activity, releasing norepinephrine and causing vasoconstriction in vascular beds, predominantly skeletal muscle. So if we unload the heart with lower body negative pressure, meaning we suck blood below the heart, sympathetic activity goes up. See, there are more bursts and they're larger. That's the normal response to a gravitational load. Minus 30 millimeters of lower body negative pressure, that's sort of like sitting up equivalent as opposed to lying down. What happened in space? Well, here's 2 weeks later in space, same astronaut. Notice that there's more nerve activity, and now when we add the lower body negative pressure, there's a lot of nerve activity, and you start to get some hemodynamic compromise. So clearly, this crew member is behaving as if they were unloaded. So the answer is MSNA is increased in space, right? But is it really? Because a couple of years ago, Peter Norsk from NASA published this study where he measured a group of astronauts pre-flight, in-flight, and post-flight, and he found in-flight blood pressure went down, cardiac output went up, and vascular resistance went down. And if you measured norepinephrine, if anything, it went down. So how do we reconcile these two apparently contradictory pieces of information? And this is really important in understanding cardiovascular adaptation to gravity, because it depends on the reference body posture. So Peter studied all his subjects, baseline was sitting up, whereas all ours were studied supine. So if you go from supine in pre-flight to supine, or there really is no up or down in space, so to spaceflight, there's an increase in nerve activity. But remember, I told you that minus 30 on the ground is sort of equivalent to the sitting posture. Now you go from sitting to space and nerve activity goes down. So sympathetic activity goes up compared to the supine posture, but down compared to the upright posture. So whenever you think about gravity and circulatory control, you have to define your reference position. Well, this is what happened in space. What happened when these astronauts returned back to Earth? And I'm going to show you again some data from this Neurolab mission. I could show you dozens of studies, but this is just one that highlights what, in my opinion, is the key pathophysiology. So this is stroke volume measured with acetylene rebreathing at baseline, 5 minutes and 10 minutes of upright tilt. Now, this is NASA parlance. L minus 60 is launch minus 60 days, so 2 months before flight. And this is a absolutely normal response. As you go from supine to upright, stroke volume decreases by more than 50%. That's normal. And then because it's a 60 degree, not fully upright, there's a little bit more of a fall from 5 to 10 minutes. And this is a very reproducible response. Here's the same crew member, the same study setup, now 15 days, 2 weeks before flight. The key data, though, are in this next panel on landing day. That's return plus 0 days. This is on landing. Notice that supine stroke volume is lower, and upright stroke volume is lower still. This is about a tablespoon, a little bit more than a tablespoon per beat. That's quite low stroke volume, and that's what happens in the upright posture. So what about the reflex response to this? Well, here's the same. Next set of panels will be the same. This is now heart rate. Heart rate goes up 2 months before flight when you're tilted. It's a quite reproducible response. And on landing day, upright heart rate is much higher. So people aren't fainting because they're not mounting a heart rate response, right? We're quite confident of that. So if they can mount a heart rate response, what's happening to sympathetic nerve activity and vascular resistance? Well, here's the data, and I'm going to do something a little bit funny. For those of you who are used to looking at Barrow reflex curves, typically you look at sympathetic activity versus blood pressure. But I'm going to show sympathetic activity on the y-axis versus the stroke volume. Here's the supine data and the upright data for our astronauts. And here's just an example of a nerve recording in the upright posture pre-flight. And here's the data post-flight. Absolutely perfectly on the same line. Lot of nerve activity, so clearly there's no problem with activating the sympathetic nervous system. But what surprised us about these data is that the sympathetic response was perfectly calibrated to the stroke volume. And if you think about it, that makes sense, right? Stroke volume is what causes the pulsatile distortion of arterial baroreceptors, in addition to mean arterial pressure. So how could I prove that to you? How could I prove to you that I was right, controverting decades of baroreflex physiology? Well, this is where I dragged Dr. Markham into our fold, and we said, well, why don't we find patients who don't have any stroke volume and see what happens to their nerve activity? So David did this study, and this will never be done again, because what he found was, look down in the B panel, the last set of patients who had pulsatile LVADs. So these are patients with left ventricular assist devices. Here's a pulsatile LVAD. Here's arterial pressure, nerve activity, and ECG. Notice that the arterial pulse is completely separate from the ECG, right? There's nothing happening with the ECG. This is all generated by the device, and nerve activity looks pretty normal. And when we tilt that person up, blood pressure is a little bit more unstable, but pretty good, and there's more nerve activity. Now, look what happens to our non-pulsatile patient up on top. Now, sympathetic nerve activity is basically through the roof. There's virtually no pulsatile distortion of arterial baroreceptors. And when they go upright, there's even more nerve activity, even though there's all this ectopy. So clearly, the absence of pulsatility causes sympathetic activation. But there was still some uncertainty in the field. So Bill Cornwell said, okay, what happens if we change the flow rates in our continuous flow devices? What happens to nerve activity? So here's that study that Bill published in Circulation just a couple of years ago. Here's just look at low rates and high rates. This is arterial pressure. And here's carotid flow and sympathetic nerve activity. So when you go from low rate to high rate, you can see that when you're at 8,400 RPMs, there's a little pulsatility in the Doppler tracing, right? And when you speed the pump up, you completely eliminate that pulsatility. Mean arterial pressure goes up, as does sympathetic nerve activity. You'll never see this happen under any other circumstances, where you primarily adjust a hemodynamic condition, raise mean arterial pressure, and sympathetic nerve activity goes up instead of down. And that's because of the lack of pulsatility. And this has generated, I think, some very interesting data and thinking about pulsatility in left ventricular assist devices. Now, there's another condition where lack of pulsatile distortion, this very low upright stroke volume, may play a really important role. And I don't know if you noticed when I showed you the heart rate data, I went through it pretty quickly, that the heart rate in the astronauts on landing day went from about 55 or 60 to about 95 or 100. That's a big increase in heart rate. It's 35 or 40 beats per minute. Does that remind you of any condition? Any electrophysiologists in the room? EPs? You take care of patients with POTS, for example, postural orthostatic tachycardia. And we said, well, maybe spaceflight is a model of patients with POTS. And so Chi Fu from our lab did a whole series of studies in this particular condition. And POTS is a disease mostly of healthy young women, and it's characterized by a very high upright heart rate. So here's some data with healthy men in yellow, healthy women in pink, and patients with POTS in green. At baseline, 30 degrees of tilt, that's half a gravitational gradient, and over 40 minutes of upright tilt. Notice that everybody's heart rate goes up when you tilt them, but POTS patients go really high. That's a 40 beat per minute rise in heart rate. And no wonder they don't feel very good. Its pulse is 120 while they're standing. What do you think happens to the stroke volume in these patients? It's an absolute perfect mirror image. So this high, I would contend that this high heart rate is because of this low upright stroke volume. And I'd call it appropriate rather than inappropriate tachycardia. So why do they have such a low upright stroke volume? Well, it turns out that they have really small hearts. Here's left ventricular mass by MRI in men, women, and POTS patients, and it's dramatically lower, as is the plasma volume. So they have small atrophied hearts with a low plasma volume. And Satish Raj and I looked at patients from the Dallas Heart Study, and they have a normal distribution of left ventricular mass. This is a histogram of LV mass in almost 270 women from the Dallas Heart Study. And here's our POTS patients, literally 2 standard deviations below the mean. So we have affectionately developed a mnemonic to help people remember this pathophysiology. We call it the Grinch syndrome, because the Grinch had a heart that was 2 sizes too small. So the patients don't love me for calling it that, and so I want to make, it's not meant to be insulting, but only to help us focus on the pathophysiology. And so I ask once again, how could I prove to you that I was correct, that the problem is the heart is too small? Well, I got to make the heart bigger and see if the problem goes away. So we did that, and we put people through a training program. I love rowing for this purpose. First of all, you can do it sitting down. Second of all, each time you pull on the oars, there's a huge increase in arterial pressure. Mean arterial pressure goes up over 200 millimeters of mercury. It's sort of weight and endurance training for the heart. So here's the data I showed you before. Healthy women, supine and standing heart rate. POTS women, supine and standing heart rate. And after 3 months of training, both the supine and the upright heart rate were markedly lower, and 2/3 of them no longer met criteria for POTS. We've now implemented this program in hundreds of women around the world with virtually identical results. So it's a quite compelling and relatively straightforward way of directing your therapy to the pathophysiology with great success. And, as we might hope and expect, their sympathetic nerve activity was reduced. Here's before training, supine and upright. This is basically a burst per heart rate. And after training, it's reduced dramatically, much more so in the upright position than the supine position. So our lab has spent a lot of time, if stroke volume is the problem, our lab has spent a lot of time trying to figure out why is the upright stroke volume so low under these conditions, bed rest, spaceflight, POTS. And so we developed a technique where we do a right heart catheterization. We use 3D echo to look at volumes, wedge pressure to estimate left ventricular end diastolic pressure. We unload the heart with lower body negative pressure, and then we load it with a rapid saline infusion. 200 mLs a minute, 15 and 30 mLs per kg. And we can draw these Starling curves. Here's a group of individuals in yellow before, this is baseline LBNP and saline infusion, before and after bed rest. And I have to say, this really surprised me. I really thought that we were just going to drift down this same curve and they would just be unloaded, but in fact, that's not what we found. We found that particularly below baseline, for the same filling pressure, the stroke volume is lower. And that's, for the fellows, let me also emphasize that it's the thing that you don't expect in medicine and science that you learn the most from. Don't worry about not finding what your mentors want you to find. This is where we really learn something, when it's different than we expected. So we said, well, why should this be? And I'm not going to show you data about contractile function. Trust me, preload occludable stroke work and contractile function were normal. So it had to be in the pressure volume curves. I'm going to now take this graph and flip it on its side. And now I've got volume on the x-axis and pressure on the y-axis. Yellow, again, is pre, and white is post. And you can see this leftward shift in the pressure volume curve. So at any given wedge pressure, the volume is smaller after compared to before bed rest. Now, I showed this to John Tyberg, the famous pericardial physiologist from Calgary, and he said, this is just unloading the pericardium. So I said, okay, let's bring these same people back. We brought him back a year later, and we repeated the same study, but we gave him a diuretic. We gave him 10 milligrams of IV Lasix to mimic the loss of plasma volume that we saw with bed rest. And look what we saw, exactly superimposable pressure volume curves. And what's most interesting to me is this one right here. Look how much smaller the equilibrium volume gets. V0, the equilibrium volume, that's the volume in the heart when pressure equals 0. That's the pressure below which you've got to squeeze in systole to engage restorative forces. So the heart pops back, push down on that, tighten in the connective tissue, suck blood back in. And we almost 50% reduction in the V0. So why should that be? What's happening to the heart that's making the equilibrium value so much smaller? So we turned to cardiac MRI and tried to characterize ventricular mass and morphology with bed rest. Excuse me. So we took a group of individuals and we put them to bed for 6 weeks. And here's left ventricular mass at baseline. 2 weeks, there's a small change, and at 6 weeks, a quite marked change in left ventricular mass. Now, we convinced 3 of these guys to stay in bed for another 6 weeks. That's 12 weeks of bed rest. You can't get up even to go to the toilet, okay? 12 weeks of bed rest. And what we found was a steady fall in left ventricular mass the whole time they were in bed. In many studies, it's about 1% a week. It just is a progressive, inevitable fall in left ventricular mass. And we've done lots of studies over the years in this space. Let me try to summarize them for you. Here's the percentage of baseline left ventricular mass scaled to body size. And baseline is this open bar. And there's 2 weeks, 6 weeks, 8 weeks, and 12 weeks of bed rest. And then 3, 6, 9, and 12 months of training. So if you just look longitudinally, that's about a third of the heart's muscle mass is plastic, adaptable, responsive to changes in physical activity. If I look at the outer edges of this adaptive range, let's take patients who have a spinal cord injury, who haven't moved in more than 2 years. I will tell you that they have about a 25% loss of left ventricular mass, and it's almost the same as patients with POTS, 25% below normal. And Martin Millikan and his group with Jerry Mitchell showed that cross-sectionally runners have about a 50% greater LV mass. So that's probably that physiologic range. 75% of the heart's muscle mass is responsive to changes in physical activity. And if you look at this graph, you say, well, I wonder what would happen if we did this while we were in bed. What if you exercise trained while you were in bed? Could you prevent that atrophy, that loss of muscle mass? So we did that study. And of course, we used rowing because we didn't have to make people stand up. And this is a pressure volume curves, volume on the x-axis, pressure on the y-axis, before and after 5 weeks of bed rest. Again, a leftward shift of the pressure volume curve so that at any given distending pressure, the heart is much smaller after compared to before bed rest. What do you think happens if you row while you're in bed rest? Completely prevents that response. Completely prevents it. So rowing, exercise training while in bed completely prevented that atrophic response. Well, that's only 5 weeks, right? It's not that long. What about if we were to go longer? And in fact, the International Space Station provides a great model for that because the astronauts are up there for 6 months in flight. So we did that study and we looked at the astronauts before, during, and after 6 months in space. And this slide, which the baseline data were published by Negishi and with Jim Thomas assisting us in this study, looking at left ventricular end diastolic volume at a few different gravitational gradients on Earth. In the supine position, representing space, 22 degrees, that reflects the gravitational gradient on Mars. That's what it's going to be like when we land on Mars after a trip there. The gravitational gradient at 41 degrees, equivalent to a lander. That's the G-force when you come back down. And then fully upright on Earth. And of course, left ventricular volume goes down when you stand up. We pretty much knew this. Now, when you come back down to Earth, after spending 6 months in space, the LV volume is smaller than you were in the supine position, but larger than the upright position. And when you tilt someone to Mars, if we were to get out of a space capsule, it's still higher than the upright position on Earth. And what's interesting is what we saw during, this is flight day 30 and 2 weeks before coming back, virtually all the astronauts actually had an increase in LV size over that period of time. And I'll show you why in a little bit. Let me just share one little interesting tidbit of data with you, which is our tissue Doppler velocities. We did a lot of other things. The Negishi paper talks a lot about strain and strain rate imaging if you want to look at gravitational effects on some of these novel echo images. But you can see that gravitational gradients influence tissue Doppler velocities. It is not load independent. Anyone who thinks that any Doppler measure is load independent, please see me afterwards. And see what happens when you land. Okay, actually tissue Doppler velocities are pretty good. You know, they're lower than upright, but higher than supine. And we saw the same pattern that we saw with left ventricular volume over time and space. Well, what happened to left ventricular mass? Well, we measured that with MRI before and after, and frankly, left ventricular mass was within 1 gram, as it was 6 months before they took off. So this surprised us. Why should it have been so stable? And it turns out that the astronauts do a lot of exercise in space. They're timed for almost 2 hours a day of weight training and running and cycling. Let me just give you an example, share with you 2 different edges of the spectrum. Here's our fittest astronaut, who started with left ventricular volume of about 165 milliliters and a mass of 178 grams. And after flight, he had about an 11% reduction in his LV mass. It's about half what we expected from the 1% per week mark. Compare him with our least fit astronaut. You can tell she's a lot smaller, a woman. In fact, her heart got bigger. She developed physiologic hypertrophy while in space. And she told us that she never exercised anywhere near as much on the ground as she did when she was in space. So this is physiologic hypertrophy on top of physiologic atrophy. And if I try to plot that on the same graph, what we've done is I won't go into the details, but using beat-by-beat blood pressure recordings, we can calculate ambulatory stroke work. And if you plot the change in stroke work versus the change in LV mass, it's a remarkably good regression. So the more they trained compared to what they did on the ground, the less atrophy they had. So this is 6 months in space. Interestingly, we looked for delayed enhancement and we saw none. We actually saw one person who had a little delayed enhancement before flight as well as after flight. She was an elite marathon runner, which is why you see it right at that RV-LV insertion point. But it wasn't spaceflight induced, it was there beforehand. And we didn't see any change in T1 times or extracellular volume. So I'm not terribly worried about the effect of the heart in space. Interestingly, we saw a little bit of a different pattern in the atria. So I told you the ventricles didn't change at all, but we measured both LA and RA size, and left atrial maximal volume got bigger. This is both on the ground, right, after 6 months in space. And we did some P-wave signal averaging and measured the filtered P-wave duration and root mean squared of the P-wave signal average and showed that it actually did decrease, which in the back of my mind makes me a little bit concerned with a 2-year mission to Mars, which we'll talk about in a minute, whether these middle-aged men and women are going to be at risk for atrial fibrillation. We didn't see a lot of increase in supraventricular beats. This is Holter monitoring over the entire duration of the 6-month recording, 6-month flight, except for one person who went from 0 to 6,000 extra supraventricular beats in 48 hours. She didn't develop AFib, but she had a lot of supraventricular beats. So who knows, maybe AFib will be a problem going forward. But this leads us naturally into what happens when you train over a very long period of time. Because one characteristic of older creatures is that they become more sedentary. And so that's been the focus of a lot of our work over the past decade, where we've taken a group of elite masters athletes. All these individuals are over 65. The athletes had to have trained for more than 25 years, at least 20 miles a week, generally much more, and be competitive at a regional and national level. We highly screened a group of sedentary but healthy elderly individuals. They had to do less than 30 minutes a day, less than 3 days a week, and have no chronic illnesses. And here's their pressure volume curves. This is a little different than what I've shown you before because it's got transmural pressure on the y-axis. That's left atrial pressure minus right atrial pressure. So effective myocardial compliance, the slope of this curve. And here's a group of sedentary young individuals and our healthy masters athletes. So you can see that sedentary but healthy aging led to a leftward and upward shift of this pressure volume curve. So not only is the heart less distensible, much smaller for the same distending pressure, but the slope of this line is much steeper. So the heart is more stiff, less compliant. Well, what do you think the hearts of our masters athletes look like? You think they were like the sedentary individuals? Superimposable with the healthy young people. So a lifelong pattern of at least highly intense competitive training completely prevented this atrophy and stiffening of the heart with aging, which is very interesting pathophysiologically, but it's not a very good public health measure, right? I can't really expect people to do that much exercise. So we partnered with our colleagues at the Cooper Clinic and we selected people who had been very consistent over 25 years with how much exercise they did. No, we didn't actually study Dick Cheney. I'm just using him as an example of a sedentary person. But we called sedentary less than 2 days a week, casual exercise, 2 to 3 days a week over a 25-year period, committed exercisers, people who did 4 to 5 days a week, and then a whole new group of competitive athletes. So all we did was select on frequency. You know, there's a lot more to, Jonathan will tell you, there's much more to the exercise prescription than just frequency. But it turns out that we were pretty good. You know, if you look at VO2 max here versus sedentary, casual, committed, and masters athletes, it's a quite linear response. So although it's a little bit of a mixed group, we're pretty good at separating fitness by doing this. What do you think happened to their pressure volume curves? Here's the data I showed you before. And here's a brand new group of sedentary individuals and masters athletes. So this is now a whole nother 50 people. I'm confident that this is right, that sedentary aging leads to a stiffening of the heart. Masters athletes keeps it compliant. 2 to 3 days a week of casual exercise, no effect. Virtually no effect of 2 to 3 days a week. Sorry. 4 to 5 days a week got you almost as good, almost the same as being an elite masters athlete. So 4 to 5 days a week is that sort of minimal dose that you need to be able to preserve this particular component of the aging circulation. Then the same thing is true with the large arteries. I'm not going to show you data about that. So why should that be? Well, I'm showing you this picture of right ventricular cardiomyopathy only because it's filled with fat. The right ventricle is replaced by fat, and it turns out that fat in the heart isn't a good thing. Here's some data from Roger Unger, where he did a biopsy, cardiac biopsy of someone with a BMI of 42 and a BMI of 27. All this red stuff, that's fat in the heart. And that causes an inflammatory response called lipotoxicity. And we can measure this fat in the heart non-invasively. We don't have to do biopsies. You can use cardiac MR spectroscopy and take a sample volume here in the septum, and here's tissue water, and here's myocardial triglyceride. And you can quantify how much fat there is in the heart. Jonathan McGavick did this a few years ago, looking at lean, obese, patient with impaired glucose tolerance and type 2 diabetes, and showed that there was a substantial 6-fold gradient of fat in the heart. Now keep these numbers in mind, right? This is 1.2% versus 0.5% myocardial triglyceride concentrations. Because we looked at over 150 healthy men and women of a broad age range and fitness levels. And we divided the amount of fat in the heart into quintiles from 0.3% all the way to 1.6%. I mean, that's more than diabetics have, right? And interestingly, the more fat they had in the heart, the lower the peak VO2. And so one of the things we wonder, let me also show you, and they had, if I look at the low-fat hearts versus the high-fat hearts, the low-fat hearts had hearts that were much more compliant and distensible. So perhaps one of the things that exercise does is it sustains high rates of cardiac metabolism, minimizing myocardial triglyceride deposition and preventing lipotoxicity. Now, okay, that's great. What happens if I take those sedentary seniors and I train them for a year? Can I make their hearts more compliant? Reasonable question. Well, we certainly made them fitter. Right, here's baseline 3, 6, 9, 12 months of training. And we trained them hard. You know, they were doing 5, 6 hours of exercise a week by the end of the year. But we couldn't change their cardiac compliance at all. Here's our masters athletes, our sedentary individuals before training in the filled circles, and the sedentary after training. Absolutely no change in their pressure volume curves. We also looked at their aortic compliance. Here's a group of masters athletes, pre and post, no change at all. Well, that's a little bit depressing, right? But it does tell you that if what you want to do is change or reverse the effects of sedentary aging, waiting until you're 70, the average age of our subjects, is probably too late. So in our most recent data, we did 2 things. We wanted to start earlier, age 40 to 60, which turns out that's when the stiffening begins. We wanted to train them longer, not just 1 year, but 2 years. And we wanted to build them up to include high-intensity interval training. And Aaron Howden just published these data last month. And the American Heart Association, I will say, told me that if you count up the number of people who saw this, read it, downloaded it, heard it on a radio, 500 million people heard a report about this study in the first 2 weeks in January. So it got a lot of fuss. Here's our about 60 individuals with their, again, pressure and volume curves. Here's pre. Now, we did a control group where they did yoga, okay? And so yoga's great, makes people feel good, but it doesn't change cardiac compliance at all. However, this time, we actually had a quite dramatic change in cardiac compliance. So if you get in at that sweet spot early enough and pick the right dose 4 to 5 days a week, we can actually reverse the effects of sedentary aging. Our current study, funded by the American Heart Association, SFRN, in prevention, we're now trying to take the same concept and apply it to patients at highest risk for heart failure, particular HFpEF. So we're taking patients with LVH who have elevated biomarkers, so let's call that stage B HFpEF, and we're training them for a year. Baseline, I'm sorry, this just emphasizes how important this is. This is Ian Nealon's data showing that if you have LVH and a troponin elevation, the cumulative incidence of heart failure or death is extraordinarily higher than if you don't. So here's the baseline for our LVH before. We now have 35 subjects who are going to do exercise training, another 35 doing a control group. They're not all finished yet, so I can't show you the data, but we're hopeful because, interestingly, they're not any stiffer than our control patients. Not yet, anyway. So we're quite hopeful that this will make a difference. Now, I want to finish by just talking a little bit about the future, okay? Because NASA's goal for spaceflight is 2-year missions to Mars. So if you, around 2030s, maybe for you or you in the background, you'll be around for this. I don't know that I will, but once we start actually colonizing Mars, it takes 2 years to get there. And the average age of the astronaut corps is about 45. And I'm telling you, they're not, high-fit athletes. Their average VO2 max is in the mid-30s. They're smart people, but they're not physical specimens. And so far, all the deaths in space have been due to catastrophic failure of the space vehicle. But if I were to ask you, take a middle-aged man and woman, or woman, send them for 2 years, what's the thing you worry about the most from a catastrophic medical problem? It will be an acute coronary syndrome. So we've been screening the astronauts with coronary calcium scores. You can't get into the Corps if you've got a calcium score over 0 now. And that's because it's really expensive to train an astronaut. But in our legacy astronauts, this is a group of 11 of them who have, a fair amount of coronary calcium, some of them over 200 coronary calcium. So this is a real deal. It's a real issue. And the question, though, is how do you calculate or estimate risk in a younger person? Do you use the pooled cohort risk equations? How many people use the pooled cohort risk equations to assess risk? Yeah, looks like most of you, those who are courageous enough to raise your hands. Well, we're working, I'm at Kira, working with the flight surgeons and MESA and DHS, the Dallas Heart Study, and the prospective Army Coronary Calcium Project. We merged patient-level data, restricted the cohorts to 40 to 65, and used an ASCVD endpoint to see if we could come up with a better tool. And we call it the ASTRO-CHARM, the Astronaut Cardiovascular Health and Risk Modification Score. And you can go online now, astrocharm.org. You can put it in. It's the only calculator that calculates ASCVD risk and includes coronary calcium. It's the only one that restricts it to that middle-aged group. MESA has a calculator, which is all the way up to 85 and just has CHD death. And so you can calculate using coronary calcium and add it into the pooled cohort equations. And it does a pretty good job, It gets our, here's the pooled cohort equations, and here's ASTRO-CHARM. So the NRI, the net reclassification index, is 12%, so highly statistically significant, pretty good. And we calibrated it then in the Framingham Heart Study, and that's currently in revision at Circulation. I hope that you'll see it out soon. So I want to leave you with a few take-home messages. The first is that The sine qua non of the cardiovascular adaptation to microgravity is a reduction in stroke volume in the upright position, which is the key mechanism underlying syncope. The cardiovascular system is remarkably plastic. It atrophies and stiffens in response to deconditioning, such as bed rest or aging. We call that the couch potato's heart. And hypertrophies and becomes more compliant in response to training, the athlete's heart. When these two stimuli are superimposed on each other at the right dose and at the right time, this deconditioning response can be prevented. For long-duration spaceflight, like with aging or bed rest, the current prescription seems sufficient for most astronauts, preventing cardiac atrophy and preserving orthostatic tolerance and exercise capacity. However, there may be an increased risk for atrial fibrillation, and we'll just have to see about that. Sympathetic nerve activity, however you want to measure it, is increased in space compared to the supine position, but decreased compared to the upright position. This change in sympathetic nerve activity is a direct function of stroke volume and its effect on arterial baroreceptors, which is why it's so important for LVADs and POTS and orthostatic hypotension. When stroke volume is preserved, sympathetic activity in the upright position is normalized, and orthostatic intolerance can be prevented after spaceflight or analogs like POTS. Finally, I don't think spaceflight appears to induce any fundamental impairment in reflex control of the circulation, emphasizing this remarkable adaptive capacity of the human circulation. Now, if you don't mind, I want to end, I've got a couple of minutes, I want to end with a little bit of philosophy in our challenging times. This is a picture of the Earth, one of the most important pictures ever taken in the space program, because it shows the Earth from the position of the moon as a unique place in our galaxy. And Carl Sagan, the great philosopher, said, there's no sign of humans in this picture. Not our reworking of the Earth's surface, not our machines, not ourselves. From this vantage point, our obsession with nationalism is nowhere in evidence. These Apollo pictures of the whole Earth conveyed to multitudes something well known to astronomers. On the scale of worlds, to say nothing of stars or galaxies, humans are inconsequential, a thin film of life on an obscure and solitary lump of rock and metal. But in 1977, the Voyager space capsule was shot off. Some of you in the room, many weren't even born then, and it was sent on a mission to explore our solar system. In 1990, Valentine's Day 1990, it passed by Pluto. And Carl Sagan convinced the JPL engineers to turn the cameras around and take a picture back of the Milky Way from Pluto. And this is what he saw. That's the pale blue dot. That's Earth from the perspective of Pluto. And what Sagan said in a speech he gave at Cornell University, he said, for us, it's different. Look again at that dot. That's here. That's home. That's us. On it, everyone you love, everyone you know, everyone you ever heard of, every human being who ever was lived out their lives. The aggregate of our joy of suffering, thousands of confident religions, ideologies, and economic doctrines. Every hero and coward, every mother and father, every superstar, supreme leader, saint and sinner in the history of our species live there on a mote of dust suspended in a sunbeam. Think of the rivers of blood spilled by all those generals and emperors so that in glory and triumph they become the momentary masters of a fraction of a dot. There is perhaps no better demonstration of the folly of human conceits than this distant image of our tiny world. To me, Sagan, it underscores our responsibility to deal more kindly with one another and to preserve and cherish the pale blue dot, the only home we've ever known. So thank you for your attention. I'll be happy to answer any questions.
Any questions? John?
Ben, thanks. That was fantastic as usual. Just a couple kind of questions. In regards to the POTS patients, your exercise prescription that you give to them, I was just wondering if you get a little bit more detail. I'm just curious in terms of how much isometric versus isotonic.
So there are a couple of things that make the program unique, right? Because if it was easy, everybody would do it, right? And we start them sitting down is the most important thing. We don't let them stand up at least for a month, sometimes not 2 months. And we give them a calendar day by day for 3 months. We tell them exactly what to do, when, and how long. And it's a progressive program. We start 3 days a week for 20 minutes. And every single session, we increase in duration or frequency or intensity. And by the time they're up to 3 months, they're doing steady state workouts and occasional interval strength training. And if they can complete that, and the majority of them can, virtually all of them feel dramatically better, and most of them no longer meet criteria for POTS. If you want the details of the program and the calendar, anyone who wants, just email me. We'll send you detailed instructions. That's what we did in our international registry. We just sent it out to the doctors all over the world, 300 patients.
Thanks. And then just follow up on the most recent data set that you obviously just got published. Echocardiographic parameters in terms of change in atrial size. Was there any after that 2 years?
Changes in
Atrial size or other?
Yeah, it's very interesting. And some of those data, Mildred Opondo is going to publish the data at the maximal load at 10 months, and we're working on the 2-year data right now. So in contrast to the left ventricle and the left atrium both got bigger, of course, right? The left ventricle, at that, we incremented them to 10 months. At the end of 10 months was our peak training load. 2 intervals, 3 base training sessions, 2 strength training sessions. They were working hard. And then we dropped down 1 less interval, kept them at that way for 14 months, and there was no further change in left ventricular size. But left atrial size continued to get bigger. Yes.
In our patients who have LVADs, they commonly develop hypertension, and I'm wondering if you think that potentially could be related to increased sympathetic nerve activity, and whether digoxin and its impact on baroreceptors, would there be any concept that might play a role?
Yeah, it's a really interesting question. So I'm not a huge fan of DIG as a primary baroreceptor sensitizer. I think, one of the things I've wondered is whether these would be especially good candidates for renal denervation, or perhaps the barostim, something that, the low-level baroreceptor stimulator, because they're just not getting stimulated, and I think that's the problem. You could talk about giving guanfacine or essential sympatholytic agents. The challenge then, of course, is then you get hypotension. And the big challenge for all of you who deal with these patients is how hard it is to measure the blood pressure. It's just not so easy to do. And so you're always stuck with, well, what actually is the blood pressure? I mean, it's hard enough to do it in the clinic. Just a quick survey. How many people in this room know how an oscillometric blood pressure cuff measures blood pressure? And I want anyone who's watching this outside to raise their hands if you think you know how an oscillometric blood pressure cuff measures systolic blood pressure. Anybody think they know? It turns out it doesn't measure systolic blood pressure. It makes the number up. All an oscillometric blood pressure can measure is a mean pressure, right? It imparts a little oscillometric impulse, and the maximum amplification is the mean pressure. And then it makes up systole and diastole based on an algorithm that nobody has any idea what it is because it's proprietary. And each company has a different algorithm, and the FDA does not require them to release it, nor do they require the companies to validate it in patients who are obese. They do not require them to validate it in older people. And so we make so many decisions based on data that are a bit suspect. And I think at least in the LVAD world, at least you guys use Doppler and you're very careful because you have to be, but it's hard to know what blood pressure you're measuring.
And just another question, if you wanted to get by with the minimal amount of time exercising, would it be rowing? Would it be rowing?
So I think what matters is doing whatever you're going to do, right, and whatever you like. Rowing is a great one. I love rowing. But I think cross-training is effective. I would do 4 to 5 days a week. Here's my prescription for life, okay? 4 to 5 days a week over the rest of your lives as part of your personal hygiene. Not something you add on at the end of the day, right? You brush your teeth, you take a shower, change your clothes. These are things you do for your personal hygiene, and your exercise needs to be considered just like that. One high-intensity interval session a week. I like the 4x4, 4 minutes at 95% of max, followed by 3 minutes of recovery, repeated 4 times. It's an old Norwegian ski team workout. It's very effective, even in patients with heart failure, by the way. One longer session lasting an hour or so. Again, I don't care what it is. It could be doubles tennis. It could be square dancing. It could be Zumba class. I don't care. Something that's fun and enjoyable that lasts at least an hour. 2 or 3 days of moderate intensity, 30 minutes, a little bit shorter breath, a little sweat on your brow, the talk test, but you could still carry on a conversation. And if you feel like it, 1 day a week is strength training. So that's my prescription for life. Yes, ma'am.
Would there be a downfall? Will there be a downfall for someone training high intensity, like Orange Theory, 3 to 4 days a week on their heart compared to doing the interval training stuff that you mentioned?
Sure. So the Orange Theory is no magic to that. Of course, that just uses heart rate guidelines. And if you're doing it correctly, it's not a bad way to monitor and characterize and quantify the intensity of your training. You know, if you do 2 or 3 high-intensity sessions a week, I think that's not bad. So you know, this is not the issue that Jonathan talks about when you talk about the extreme athlete, 20 to 40 hours a week, 100, ultra distance marathons where you get cardiac fatigue and may actually cause deterioration of ventricular function. We're still only talking about, 4 to 5 days a week, and even an Orange Fitness high intensity session is nowhere near the kind of volumes that we see in the athletes who have cardiac fatigue. Whether that's good or bad, we can still chat about.
One thing that's interesting is you look at the elderly, they talk about that the only activity, only measure that changes the course of this is activity. But as I look at your slides, I'm not sure that you would agree with that.
So I don't want you to walk out of here saying 2 to 3 days a week of exercise is of no value. I mean, of course it is. We know that a large reduction in cardiovascular mortality happens even at just that transition from being sedentary to low levels of physical activity. So I think it's absolutely critical and important to do something. And I think that does play an important role. It modifies endothelial function. It improves vagal tone. It reduces clotting. So there are lots of things that even a modest amount of exercise does, but it won't change cardiac and vascular structure.
We occasionally run into patients who have hypertrophic cardiomyopathy, real small ventricles, small stroke volume, hypotension. Is there any reason to think that rowing would be helpful for those patients?
Well, it's a great question, and I think exercise sitting down can be very beneficial, especially for those who have very high gradients in the upright posture. You're catching me at a good time because last week we just started the first high-intensity exercise training study in HCM. The RESET trial, led by the Michigan group, showed that moderate intensity exercise in HCM was safe. But it didn't really increase fitness very much. Their VO2 max increased by, 5% or 6%? It wasn't much. But there are some animal studies suggesting that higher intensity training can actually alter the myofibrillar disarray with HCM. And so, we're quite interested in seeing whether the standard proscription of high-intensity exercise in HCM is really valid. We are being very cautious in patients with high gradients, of course, and we're trying to make sure that they exercise sitting down or at least sit down or lie down when they're done. We're evaluating their gradients before they start, but the first few subjects are starting just last week.
Okay, I think we'll close there. Thank you again, Dr. Levine, for being here.
Thanks.
The preceding program is copyrighted by Emory University.